Chapter 6 Comfort and Sedation. Critically ill patients experience discomfort from many things, including both treatment as well as the disease process. The Society of Critical Care Medicine is updating its sedation guidelines. At a time of publication, they'll be addressing the concept of PAD, pain, agitation, and delirium. You can check that Critical Care Medicine for updates. Unfortunately, those critical care patients commonly have alterations within their comfort, and the goal for us as nurses is to maintain that optimal level of comfort. This discomfort may be from pain, agitation, delirium, and may be difficult to differentiate. The ABCDEF bundle for preventing delirium is a newer concept. The key components are assessing the need for mechanical ventilation, along with the appropriate pain management and early mobility. The ABCDEF is an acronym standing for A. Assess, prevent, and manage pain. B. Both spontaneous awakening trial along with spontaneous breathing trials. C. The choice of analgesia and sedation. D. Delirium assessment and management. E. Early mobility and exercise. And F. Family engagement and empowerment. For pain, pain is an unpleasant sensory and emotional experience, often associated with actual or potential tissue damage. And always remember, pain is subjective. Pain is what the patient says it is. For agitation, this is marked by aggression, an intense sensation of unease, disorganized thinking, and an inability to cope with overstimulation. It often leads to increased morbidity and mortality if untreated. The assessment and prevention of delirium is a hot topic in critical care. Delirium is an acutely changing mental status, with the key word of inattention. There are many different types, from hyperactive, characterized by agitated, combative, and disoriented thinking, hypoactive, which is that quiet delirium, or mixed, which can fluctuate between the two. The physiology of pain is complex. Pain is initiated by signals that travel through the peripheral nervous system to the central nervous system. The sympathetic nervous system is quickly activated. The two pathways, both fast, sharp A delta fibers, or slow, such as the burning chronic from unmyelinated polymodal C fibers. Pain travels that nervous system to the brain. In the case of acute pain, it activates the sympathetic nervous system. For chronic pain, there's less activation. Acute pain again travels via those A delta fibers, while chronic pain travels via C fibers. The physiology of pain, nociceptors are the most abundant receptors, dealing with mechanical stimuli, chemical stimuli, as well as thermal stimuli. Fortunately, there is very little adaptation to pain and the initiation of the inflammatory response to tissue injury. The cell bodies of nociceptors are located within the dorsal root ganglia, and again, these nociceptors are the most abundant fibers. Agitation is less clearly understood than pain. It can also be more complex because there's no actual tissue injury. It involves the stimulation of the sympathetic nervous system. Again, agitation is confined within the brain, and it's a purely psychogenic disorder with no actual tissue damage occurring, and it can be linked to the fight or flight response. Risk factors for the development of delirium in the ICU include coma, advanced age, pre-existing dementia, history of hypertension or alcoholism, and a high severity of illness at admission, such as with hypoxemia, metabolic disturbances, electrolyte imbalances, and head trauma. Pain, agitation, and delirium also have many negative effects, primarily associated with physiological responses. The negative effects of pain, agitation, and delirium include the raising of catecholamines, resulting in tachycardia and hypertension. It can also interfere with healing, increased oxygen absorption, such as end organ ischemia, increased respiratory effort and hyperventilation, fighting the ventilator, or delay in ventilator weanings. Other negative effects include feelings of panic and fear, and can exacerbate everything from a lack of sleep, nightmares, feelings of bewilderment, isolation, and loneliness. The above are physiologic effects of pain. The unrecognized and untreated delirium is a predictor of negative clinical outcomes. The ICU Liberations implementation tools offer a stepwise approach to pain assessment, suggesting the assessment in this order. Number 1, attempting to obtain the patient's self-reported pain, looking for behavioral changes, asking the family to help identify pain behaviors, and assume that the pain is present. We always want to believe our patient's reports of pain. Pain assessment can also be more challenging in the critically ill patients. This can be due to many factors, such as a decreased level of consciousness, intubation, impaired communication, and in differentiating pain from anxiety. The characteristics of pain include a precipitating cause, severity, location and radiation, duration, and alleviating or aggravating factors. If you remember back to last semester, I'm a fan of the acronym OPQRST, standing for onset, provocation, quality, radiating, severity, and time. You may have previously been taught or seen the acronym OLGCARTS as well, which is very similar, standing for onset, location, duration, characteristics, alleviating or aggravating factors, radiation or relieving factors, time, and severity. There are also many assessment tools for communicative patients to rate their pain, the most common being the pain score, rating it on a 0 to 10 scale, with 0 meaning no pain and 10 being the worst pain imaginable. They may also use the visual analog scales, where the patient points to a level of pain severity on a 10 centimeter line. It can also be done with a pencil to mark the severity. There is also an application, the ICU Patient Communication app. This is a communicator that allows patients to identify where on the body they're feeling sensations, as well as the severity, pain, itching, and nausea that can all be identified with exact locations on the body, in addition to the rating scale of 0 to 10 for severity. It can be especially helpful for patients on mechanical ventilation, those with hearing loss, or speech limitations. Which pain scales do you believe would work best in the critically ill patient? And that's going to be very subjective, as it's going to be very dependent on everything from the patient's alertness and orientation to their dealing with speech limitations, hearing loss, and everything in between. There's not necessarily one scale that's the best. It's going to be which scale is the best for each unique patient situation. Vital signs are not a valid indicator for pain and only used as a cue for further assessment. Other validated tools include the Behavioral Pain Scale or the Critical Care Pain Observation Tool, located on Table 6-4 on your text. Quick quiz. The nurse is assessing the adult patient's pain. The patient is alert, oriented, verbal, and appropriate. Which scale should the nurse use to assess the patient's pain? Would that be A, the Critical Care Pain Observation Tool, B, the Behavioral Pain Scale, C, the Numeric Rating Scale, or D, the FACES Pain Scale? Since the patient is alert, oriented, and able to communicate, that answer here is going to be C, the Numeric Rating Scale. The Critical Care Pain Observation Tool and Behavioral Pain Scale are more indicated for patients who are unable to communicate, while the FACES scale is indicated for pediatric patients, not necessarily adults. When assessing agitation, hyperactive psychomotor functions can include tachycardia, hypertension, and movement, and can often interfere with care as well. You want to sedate to limit the hyperactive psychomotor functions, with the goal of maintaining the lowest effective score. The level of sedation can be measured using objective tools or scales. These adverse effects include increased hospital stays, delayed ventilator waitings, immobility, and increased rates of ventilator-associated pneumonia. Conversely, not enough sedation may lead to agitation, inappropriate use of paralytics, increased metabolic demand, and an increased risk of myocardial ischemia. There are also several tools available to compare the similarities and differentiations of sedation. The RASS is a 10-point scale from 4 being combative through the 0 calm and alert to -5 unarousable. The patient is assessed for 30 to 60 seconds in 3 steps using discrete criteria, whereas the sedation agitation scale, located on Table 6-6 of your text, describes patient behaviors seen in the continuum of sedation to agitation, with scores ranging from 1 unarousable to 7 dangerously agitated. Sedation medication is given to reduce symptoms, and its dose is adjusted based on tools or scales such as the RASS or SAS. The target level of sedation varies based on the disease process, therapeutic interventions, or the type of mechanical support needed. The assessment of brain waves through EEG or bedside technology may also be helpful. There are no technological devices that provide an absolute measurement, however. Some bedside options include the bispectral index score or the patient state index. Other objective measures of brain function are only recommended for those requiring deep sedation or a neuromuscular blockade. Delirium is defined as acutely changing or fluctuating mental status, inattention, disorganized thinking, and altered levels of consciousness, as defined by the Diagnostic and Statistical Manual of Mental Disorders. Confusion assessment methods for the ICU include delirium positive in the CAM ICU if the following criteria are present. That would be 1, an acute mental status change, 2, inattention, or either 3, disorganized thinking, or 4, altered levels of consciousness. This assessment will include acute changes in mental status, inattention, disorganized thinking, altered levels of consciousness, and validated with tools such as the confusion assessment method for the ICU and the intensive care delirium screening checklist. Quick quiz. A patient is confused and having a difficult time focusing on when the nurse reviews the plan of care. The nurse is beginning her morning assessment. Which assessment will be vital to complete? Would that be A, the RAS, B, the CPOT, C, the numeric rating scale, or D, the KM-ICU? And that answer would be D, the KM-ICU. While pain and sedation are important to assess, the KM-ICU will assist the nurse in determining if the patient is suffering from delirium. Depending on the patient's level of confusion, the numeric rating scale may not be appropriate to use. Let's move on to the management of pain, agitation, and delirium. And the differentiation between, again, that pain, agitation, and delirium can be difficult given their similar presentation as well as assessment findings. Non-pharmacologic interventions can be effective in reducing pain, agitation, and delirium. Everything from environmental manipulation to complementary and alternative therapy like guided imagery, music therapy, animal-assisted therapy, and essential oils and aromatherapy. For clinical judgment, that non-pharmacologic methods for pain, agitation, and delirium treatment can be just as important as those pharmacological interventions. Remember, we don't want to use just one method. A variety of methods can go a long way in both magnifying the effectiveness of each of them. When dealing with pharmacological management, even with the most aggressive non-pharmacological therapies, many critically ill patients require medication to relieve their pain, agitation, and delirium. Pain should be treated before sedation is initiated or altered. Good practice in the management of pain for adult ICU patients should be guided by that routine pain assessment, and pain should be treated before that sedative agent is considered. While not without their risks, opioids are going to be another key part of necessary treatment for in the critical care setting. And they're so effective due to their rapid onset, ease of titration, lack of accumulation, and low cost. There's also multimodal analgesic approaches, such as administering analgesic medications from various pharmacological classes. So you want to combine opioids with drugs from another class. And scheduled versus as needed medications. These opioids, these pain medications can be scheduled, or they could be given as needed as the patient feels pain and requires them. Another one is going to be fentanyl patches. While not recommended for acute analgesia, because they can't take 12 to 24 hours to achieve peak effect, once the patch is removed, and another 12 to 24 hours once the medication is no longer present in the body. And while they're not used necessarily for acute setting, they're very effective for chronic pain. Among those risks and concerns with opioids, your top priority is going to be respiratory depression. Always make sure you're assessing that respiratory rate before you administer any opioid, especially on NCLEX and ATI. Also, other risks include hypertension, CNS depression, hallucinations, constipation with long-term use, and major concerns with the elderly population and geriatric population, as they may have reduced opioid requirements. Again, the administration of a reversal agent such as Narcan is not necessarily recommended after prolonged analgesia, as it can induce withdrawal and may cause nausea, cardiac stress, and dysrhythmias. Not to say don't give Narcan. If this patient's having respiratory depression and having major symptoms of overdose, give that Narcan. But we want to be aware that it can cause nausea, dysrhythmias, and major withdrawal symptoms. Some of those adjuvant medications to work in combination with opioids would be things like acetaminophen, ketamine, neuropathic agents, and NSAIDs, nonsteroidal anti-inflammatory drugs. A patient-controlled analgesia or a PCA pump may be something you see a lot as well, as these PCAs can be effective, but the patient must be able to manage the pump. It's helpful but rarely applicable to critically ill patients. The patient must be alert enough to operate the device, and may be applicable to patients in step-down or telemetry units. For me in organ transplant, we had PCA pumps a lot for patients, especially with like a liver transplant. It is a very large chevron wound in the upper abdomen, and it can be very painful. And those PCA pumps can go a long way in allowing the patient to deliver opioids, deliver medication when they're in pain, and not when they're not in pain. Another may be an elastometric infusion pump, and these are ideal for perioperative pain management or to be around surgical wound sites. It could also include an intercostal nerve block after blunt trauma with 3 or more unilateral rib fractures, and these deliver long acting regional anesthetics. The epidural route for pain management can also be effective. This involves opioid or local anesthetic and facilitates mobility and as well as pulmonary hygiene. It is contraindicated in the cases of coagulopathy, cardiovascular instability, sepsis, spinal injuries, infection of the skin, an inability to lie still, or even the patient's refusal. Spinal analgesia can have many side effects, including respiratory depression, sedation, nausea and vomiting, and urinary retention. That spinal anesthesia with local anesthetics may also have sympathetic blockade, including hypertension and venous pooling, along with motor weakness, a sensory block, and again, urinary retention. When dealing with any sedative agent, our goal is to use less sedation by titrating the sedation targets. Benzodiazepines, for example, can lead to sedative, hypnotic, and amnesic effects by binding to the GABA receptors that facilitate the inhibitory effects. Another option may be propofol. It's a preferred sedation over benzos to improve clinical outcomes in mechanically ventilated patients. Propofol is an intravenous general anesthetic. However, it has no analgesic properties. Those of you remember several years ago when Michael Jackson died, propofol was the drug that he was taking and died on. For sedative agents, prior to administrations, we want to consider the pain management, the patient's reorientation, and promoting sleep. Other pharmacological treatment for agitation include benzos, again, propofol, and we want to titrate to the endpoint using the sedation scales. The nurse is concerned about administering opioid medication to a patient in pain because the patient is weaning from mechanical ventilation. The nurse consults with a clinical pharmacist who suggests trying A. Neuromuscular blockade, B. PCA pump, C. A sedative such as lorazepam or Ativan, or an NSAID, a nonsteroidal anti-inflammatory agent. And that answer is going to be D, the NSAID, to work as an adjuvant medication. Tolerance and withdrawal is going to be another major concern due to the prolonged high-dose opioid or sedative therapy. You want to collaborate with a multi-professional team to develop a plan for tapering. Opioid withdrawal symptoms include pupil dilation, sweating, rhinorrhea, tachycardia, hypertension, tachypnea, vomiting, diarrhea, increased sensitivity to pain, restlessness, or anxiety. Keep in mind, opioid withdrawal looks very similar to a flu from a clinical perspective. It really does look like a miserable form of withdrawal. Not to be confused with signs of benzodiazepine withdrawal, which include tremors, headaches, again, nausea, sweating, fatigue, anxiety, agitation, and an increased sensitivity to light and sound. This benzodiazepine withdrawal is going to look very similar to alcohol withdrawal in that respect. Wrapping up, let's discuss other special considerations. When dealing with invasive procedures, we want to assess and manage the patient's comfort before, during, and after the procedures. The patient appears sedate but can verbalize. Their role during these procedures or conscious sedation is to monitor their vitals and ensure the patient's airway and observe for any adverse effects of the treatment. For neuromuscular blockade, this is indicated to facilitate treatment or procedures including emergency or difficult intubation. It can also improve the tolerance of mechanical ventilation, especially with non traditional modules, and can also manage elevated increased intracranial pressure. There is no sedative or analgesic properties and must provide analgesia and sedation. You also want to monitor the levels very closely and carefully assess any patient with this. When dealing with the train of four testing, the TOF evaluates the level of neuromuscular blockade to ensure that the ordered amount of neuromuscular blockade is achieved with the lowest dose of the medication. The ulnar nerve and the facial nerve are the most frequently used sites for peripheral nerve stimulation. The peripheral nerve stimulator delivers four low energy impulses, and the number of muscular twitches is from there assessed. The four twitches of the thumb or facial muscles indicate incomplete neuromuscular blockade, while the absence of twitches indicate complete blockade. The TOF goal is 2 out of 4 twitches. Another major consideration is going to be patients that have substance use disorder outside of the hospital, because they're going to have a much higher than normal threshold as soon as they come into the unit. The management of pain and agitation is often complicated, and especially with alcohol. Alcohol withdrawal usually presents within 72 to 96 hours after the patient's last alcohol intake. So it can have a significant delay in that patient could be admitted for several days before withdrawal symptoms begin to manifest. These patients often need higher than usual doses to control their symptoms. We want to be assessing for alcohol withdrawal very closely. For unmanaged pain, that can also trigger inflammatory cascade, increasing morbidity, costs, and the hospital's length of stay. The elderly will also have a lot of special considerations, such as physical changes associated with aging, increased comorbidities, multiple medications, and polypharmacy becoming a very real concern, and combined with their physical frailty as well as cognitive and sensory deficits. For our key takeaways from this chapter, pain, agitation, and delirium are interrelated concepts that are common in critically ill patients. The guidelines provide a clear evidence-based roadmap to manage pain, agitation, and delirium in these patients. If not effectively managed, pain, agitation, and delirium can increase morbidity and the mortality of critically ill population. Again, that patient is the true authority of the pain they experience. Therefore, what they report is what their pain is. We always believe our patients' statements of pain. There's also, again, those several tools, finding the best tool to assess their pain, putting a numeric value on there, having an objective measurement for a subjective report, a subjective symptom. And given the interrelationships among pain, agitation, and delirium, their management's complex. We're not just treating pain, we're treating our whole patient. And again, don't forget the non-pharmacologic approaches as well. We don't just want to use medication, and we don't just want to use non-pharmacological approaches. We want to combine many different interventions to most effectively manage their pain. Also, the management of delirium that can be complex, and managing those symptoms effectively can go a long way to improving the outcomes for your patient. But anyway, that's all we got for this chapter. I'll see you in the next slides.